Now let's look at fluoride varnish application. Fluoride varnish is a thin protective coating painted on the teeth. It can be applied at well child visits or even sick visits if the child will tolerate it. Most products contain 5% sodium fluoride in a viscous resinous base. The varnish forms a sticky layer on the tooth and hardens on contact with saliva. It adheres to the enamel and forms a depot from which fluoride is slowly released for many hours after the application. Developed more than 30 years ago in Europe, the varnish stops or slows demineralization of the tooth and promotes remineralization where teeth have begun to decay. It is most effective when used on early white spot lesions that still have an intact surface layer. Most studies have shown a 25 to 45% reduction in dental caries with regular applications. No published evidence exists showing fluoride varnish applications place a child at risk for enamel fluorosis. The Smiles for Ohio training manual provides copies of research that demonstrate the effectiveness of fluoride varnish in reducing caries in very young children. A study by Weintraub and others, published in 2006, shows a clear dose-response effect. The Cochrane collaboration published a meta-analysis that pooled data from 3 clinical trials and showed a preventive fraction of 33%. Fluoride varnish applications have distinct advantages over the more traditional topical fluoride applications. No special dental equipment is required. Fluoride varnish is easy to apply, especially using knee-to-knee positioning with parental help. A professional dental cleaning is not required. Only small amounts of fluoride are applied. And finally, the varnish sets immediately upon contact with saliva and is well tolerated by infants, young children, and those with special healthcare needs. The supplies needed are minimal. Gloves, 2x2 gauze squares, and the varnish are all that is required. Most varnishes come in unit dose packages containing a disposable applicator brush. These can be available in each exam room. Another suggestion is to roll the supplies in a pair of gloves and leave the fluoride varnish packets in a centralized nursing station for easy accessibility. Fluoride varnish is available in economical larger tubes as well. The provider squeezes a small amount on a gloved hand and applies it with a disposable brush bought separately. The following video clip demonstrates actual fluoride varnish applications in 2 children of varying ages. The application for the older child took approximately 1 minute and 50 seconds. With gloved hands, dry the teeth to be treated with the 2x2 gauze sponges. Try to keep the teeth as dry as possible right up until you apply the varnish. Apply a thin layer of varnish to all surfaces of the teeth. You will usually be able to isolate a quadrant at a time, but may have to work with fewer teeth in some children. Fluoride varnishes contain a concentrated dose of sodium fluoride which, when placed on the teeth topically, help remineralize the enamel. Fluoride varnish will disrupt the progression of tooth decay and can actually reverse early carious lesions. Once the varnish is applied, you need not worry about moisture or saliva contamination. The varnish will set upon contact with saliva. Infants are easiest because they have only anterior or front teeth. It takes just a few seconds to apply fluoride varnish to the 4 to 8 teeth that are present in children under age 1. You can use the gauze sponge to keep the tooth isolated from an exploring tongue. Young children may cry, but that's okay since the mouth will be open wide for good access. After the fluoride varnish is applied, give the parent or caregiver instructions about diet and home care. Do not brush until the next day. Avoid hard, abrasive foods and hot drinks. Certain brands of fluoride varnish are lightly tinted. The yellow coloring will remain on the tooth until the varnish wears off or is brushed off the next day. Note the varnish application on the patient's chart so that reapplication can occur at the appropriate interval. Medicaid reimbursement is available only when applications are at least 180 days apart. A list of commonly used fluoride varnishes can be found in the Smiles for Ohio training manual. Prices and contact information for suppliers is provided. The information should be helpful but may not be current by the time you're ready to order. The varnishes come in a variety of flavors and are packaged in various quantities. We estimate the average supply cost per varnish treatment in 2006 to be $1.25. Physicians may be reimbursed for professional services associated with fluoride varnish applications for Medicaid-eligible children from first tooth eruption to age 3. The service is billable in addition to a well or sick child visit, but should not be the only reason for the visit. Coverage is limited to one application every 180 days per provider type. The procedure should have the 3 key components of oral assessment, fluoride varnish application with anticipatory guidance, and referral to a dentist as necessary. Claims should be submitted using CDT code D1203. Applications more frequent than every 180 days will not be reimbursed. Billing instructions are available at the Ohio Department of Job and Family Services website for the diminishing number of children whose care is directly reimbursed by the Medicaid program. Most children, however, will be enrolled in Medicaid-managed care plans. Contact the plans in your area for their respective reimbursement rates and billing procedures. Other states that have implemented fluoride varnish programs in primary care practices have learned some valuable lessons. First, devise a system to identify who gets fluoride varnish applications in the practice and how it will be documented in the patient's chart. Determine what personnel will be involved in the various components of the procedure: the exam, the varnish application, counseling and referral, and documentation in the patient's record. Have one person coordinate the fluoride varnish application system in the office. Have a plan for applying the varnish at certain well child visits, but don't hesitate to do the procedure at any appointment when the child is not too ill, especially between ages 2 and 3. Have materials handy in the exam rooms or a centralized location. Integrate the oral health assessment into the examination of the tonsils and pharynx. Try the knee-to-knee position for good visibility and control. For children with back teeth, various dental aids are available to improve access and avoid bites. Additional information, including handouts for parents and caregivers, a tooth eruption chart, and a caries risk assessment tool, are available in the manual or on the CD that accompanies this training program. The American Academy of Pediatrics training program provides excellent information on oral health risk assessment. It's available on CD or through their website. Besides expanding on many of the concepts presented here, there are excellent resources available on the Internet that will further educate the primary care provider as well as the parents of the children in your practice. You can make a difference. Instituting oral health risk assessments into your well child visits, applying fluoride varnish, and providing parent education about oral health can go a long way in improving a child's nutrition, appearance, and their ability to learn. Take a dentist to lunch and begin to establish referral relationships so that your youngest patients can begin receiving early dental care. You see the children, now you have the tools, you can make a difference.